morning. I'm early today just in case people had questions, and if you don't, we can just hang out till everyone gets here.
Can our group go first by chance?
Sure.
Okay, cool, thank you.
I was just gonna ask someone to go first, so that works for me.
My boyfriend, I told him to leave at 7:30 at the earliest, and he left at 6, so he's getting here really early.
Okay.
Good morning.
Good morning. Alrighty. I'm gonna mark everybody down, and then we'll go from there. We'll probably start about 4 or 5 after, just to make sure everybody can get in here. Okie dokie. So I'll start walking us through how we're going to do this. And then hopefully our last 3 folks will sign on while I talk about it. So The dyslexia and impulsivity group has volunteered to go first, so we appreciate that. As you all do your presentations, this is the same rubric that's on the syllabus, so I'm just marking on that as you go through, so there's no surprises. You know what you're being graded on. So I will set my timer for 15 minutes, and then I will put in the chat when there are 5 minutes left and then 1 minute left. Don't freak out. 5 minutes left is, plenty of time. But I just want to make sure that, I know y'all have other exams. Some of you are packing up and leaving, all right? So I want to get us through this as efficiently as possible. So, yeah, we'll just, after each group is done, I'll just say which group wants to go next, and we'll go from there. I am more dimly lit than usual today because I can't stand to have my ring light on because our air conditioning broke. What a great time for that to happen. And we're supposed to replace it tomorrow, and now it sounds like Friday. Oh, did you finally come to visit? You haven't visited them in a while. Simba came for your presentations. But yeah, so we're all being very creative in the ways that we are trying to stay cool. And one of the ways for me is just keeping all the glaring lights off I can. So I will leave my camera on just so you can see that I am here. Just give you a heads up. Hopefully it won't happen in the middle of our class because I haven't gotten any notice about it yet. But we do have a guy from the company stopping by to bring us temporary air conditioners. So if I suddenly disappear from the screen, I am going to help him. I am recording this, so anything I would have missed in your presentation, if someone's presenting, I will go back and watch. Typically, obviously, I wouldn't just leave in the middle of a presentation, but it's a little critical since it's going to be like 91 or 92 today. So yeah, any questions before we get started, either about the presentations or anything left over for the class? You can either unmute yourself or stick them in the chat.
Are we able to share our screen to show the presentation? Okay.
All should be able to.
Okay.
For some reason you can't, let me know, because I can then give you like co-host duties, but you should all be able to.
Okay.
Can my group go after this group?
Sure. Okay, so
Perfect.
volunteer for the second group, which will be the Restless Leg Syndrome group. So awesome. If possible, I would love if you showed yourselves while you're talking during your presentation. If that's not possible, you can just show your presentation and talk. But yeah, hopefully this will be fun. I usually learn a lot, so hopefully you all will too during this part. And have our first group of Miranda, Haley, Logan, and Brittany. Go ahead and get yourself set up, and I'm going to go ahead and get my clock set up as well. Hi, yes, hello. And I'm going to mute myself, but I can unmute anytime if you have questions. There we go. Okay. So whenever y'all are ready, you can get started.
Are you guys ready?
Yeah.
Okay. Brittany, Logan, are you guys ready?
Yeah, I'm ready.
Okay. So we did developmental dyslexia and impulsivity. And here's a video. Oh,
Yeah, when you share screen, there's a little box down in the corner of the screen that tells you which one to select, and you just have to check that to have it share your computer sound. So you might have to reshare.
oh, okay. Okay. Oh, okay, I see it. And do I click optimize screen sharing for video clip as well?
Yeah, that's always really good.
Okay.
My whole life, it's been, Ryder just needs to apply himself. Ryder's smart. He just needs to work harder, focus, get it together, man up. But inside, man, I knew they were all wrong. It didn't matter how hard I focused or how hard I worked. I was stupid. And if anyone ever found that out, if they knew the real me, I was sure it would have killed my parents. Man, my dad's a friggin' PhD. How's he gonna feel about having an idiot for a son?
Sure, your dad loves you no matter what.
Dude, you learn to read when you're 6. When you're 6, that's first grade. And they separate you into these levels. They don't tell you that's what they're doing. But everyone knows who's in the smart group and who's in the dumb one. You think a 6-year-old knows his dad's gonna love him no matter what? I've been carrying the secret around my whole life, man, all this time.
You can put it down. Okay? Because the only secret is that your brain works a little differently than everyone else's. That's it. Okay?
They're gonna start an individualized education program for me. I'll start working with a special teacher every day next week. Yeah, thank you. Thank you for helping me, Finn. I owe you.
Actually, you owe Jake.
So that was for developmental dyslexia. And the theories associated with it are the phonological theory, which talks about dyslexic people. They have a special impairment in the portrayal, storage, and the retrieval of speech and sounds. And they perform poorly on tasks requiring phonological awareness. And one lack to this is that they can't completely explain the sensory and motor disorders that are associated with dyslexia with people who have dyslexia. Another theory is magnocellular theory, which states that the magnocellular dysfunctions are not limited to sight, but they're generalized to all modalities, which are visual and auditory. And they have poor performance with planning and visual and auditory, and they have visual and auditory problems. And the cerebellar theory states that the cerebellum is mildly dysfunctional and numerous cognitive difficulties occur, and speech, phonological representations, everyday tasks are a struggle as driving, reading, and writing. And rapid auditory processing theory, which states that the deficit is in the perception of short or rapidly varying sounds, and poor performance on auditory tasks such as differentiating frequencies and problems with temporal order judgments. And the visual theory states that the visual impairments result in difficulty with letters and words.
So symptoms associated with dyslexia include problem forming words, learning to take at a later age, confusing words that sound alike or like letters, because I know a really popular one is like mixing up B and P, problem remembering letters and numbers, mispronouncing words and or letters, spending an unusually long time completing tasks that involve writing, and difficulty finding the right word or forming answers to questions.
And the assessment with dyslexia is phonological awareness and phonological language-based memory, rapid automatic naming, receptive vocabulary, phonic skills, decoding, oral reading fluency, and spelling and writing. So they pretty much have them do these tests to help them better deal with their disorder and to help them like get better with learning things that they find difficulty with.
So there's no real treatment for dyslexia. It's a problem that somebody will have their whole life. But if it is caught early enough, they can find a treatment that can cater to their specific needs. Like in the clip, he said he was getting like a certain learning program. So I think that for every person with dyslexia, they have to have a different kind of treatment depending on how severe it is. But some of the best methods are self-care and psychotherapy. For quality of life issues, it can affect your ability to tell time. You may not be able to multitask. You may be scared to communicate with others, and you may not be able to remember important dates or appointments.
And this is a clip for impulsivity.
Come out.
No, you keep it there just a little while longer. Hannah.
I have to.
Really?
Just stay right where you are. Nobody moves. Stay exactly where you are.
So a little background of that clip, I don't know if y'all are Grey's Anatomy fans, but there was a bomb in a person's body. It was like shot through like a little, I don't know, some kind of gun or something. But anyways, the paramedic was like holding it in place and keeping it from exploding. And then she started like panicking. And Meredith freaked out and like didn't think and just put her hand in there, not thinking about the consequences.
Theories associated with impulsivity. There's ego depletion, which is cognitive, a concept of self-control, suppressing emotions or thoughts, learning how to approach difficult decisions, automatic versus controlled processes. Automatic processing does not require us to pay attention. It's like autopilot, and controlled requires you to pay attention and have to think about what's going on, making decisions. Intertemporal choice requires one to think about future rewards or outcomes, and inhibitory control defects in cognitive processes lead to deficiencies in functioning.
Some symptoms of impulsivity are overindulgence of certain activities like shopping or gambling. So basically, an example of that would be like if you're shopping at the mall and you see some shirts you like, you will pick them up, pay for it without even thinking about it. You won't even worry about, how much money is in the bank account. You see it, you like it, you got it. Destruction of yourself or other people's property when you're upset. Some other things are frequent outbursts of anger at random moments, physical aggression and calm moments, accelerating moments to make them more intense, and self-harm behaviors after emotional experiences.
Assessments for impulsivity, the Barra Impulsiveness Scale. It's a questionnaire that assesses the personality or behavior aspect of one's impulsiveness. It's 30 questions long and it just describes a bunch of common impulsive and non-impulsive behaviors. And then there's the Eisner Impulsiveness Scale. They're very similar. It's a questionnaire. It has 54 yes or no questions regarding impulsive behaviors and attitudes.
Some treatment methods for impulsivity is dialectical behavioral therapy, and that's basically just a therapy that helps you with your basically that helps you just with your mood and helps you change like your mood patterns and everything like that. And then there's mood stabilizers, drugs, and mindfulness meditation.
Quality of life issues associated with impulsivity. There's a lower quality of life for higher impulsiveness ratings on like the scales. There's a lesser quality for decision making, so decision making skills are not going to be as good as it normally would be. It negatively impacts those surrounding the person struggling with the impulsiveness, strains relationships with families and significant others.
And then we just have our 2 pages of and for our citations.
All right, great job, y'all. Thanks for kicking us off. I'm gonna go through and unpin you.
Great job, you all.
Thank you.
Thank you.
And while I'm doing this, if anyone has any questions for any of the group members, feel free to ask. If not, then we'll have our next group get started. So that is our Restless Leg group, which is Sophia, Carla, Kayla, and Madison H.
So for our presentation, we wanted to do something a little different and wanted to do a video instead. Is it fine if I share my screen? Okay, perfect.
Yep, go ahead. And I'm going to be very slowly pinning people. It takes me a minute, so.
If you guys can't hear the volume at all, just let me know.
Yeah, I can't hear. You might have to reshare and make sure that box is checked.
Okay. How do I do that? You know?
Yeah, so if you just go down to share screen again,
I can pull it up.
then it should, yeah, if you go, it might be at the top now, like new share or something like that. And when you do it, there'll be a box and that lets you select what you want to share. And then down in the corner of that box, there's a box that says like optimized for video.
Oh, I see it. Okay.
Just think of all the skills you all are learning that you wouldn't have had before. Oh, we got to look on the bright side, right?
Okay. I don't know if I did it. Let's try this again.
I still can't hear it. I don't know if anybody else can.
Oh, that's annoying. I don't know what to do.
The other option is you sent it to me, right?
Yeah, I don't know if the link works though, because the video said.
Let me check. Because if it works, then I can share my screen.
Okay.
And then I can make the volume is gonna work. Yeah, it looks like it's gonna work. Okay. Let me do that. Okay. Hopefully that will work.
So today is the 28th of April. Currently, I'm about to see patient Madison Hudson. She's a female that is 20 years old, currently presenting post-op with other leg pain. So that would be her right leg. Her symptoms are aching, throbbing, symptoms worsening at night, uncomfortable sleep, not getting sleep through the night, and she only has relief when she's walking. Her histories are extreme pain, especially in that post-op foot, and then she had foot surgery on her left ankle. Medications she's currently on are naproxen, obviously for pain, aspirin to make sure that she's not getting blood clots while she's not walking very much, and then oxycodone, obviously for pain relief. And then I'm going to ask the patient a couple of questions and we'll reevaluate, but most likely from her symptoms and her history and the surgery, I would guess something along the lines of restless leg syndrome, but we will find out after further evaluations. Hello, Madison Hudson?
Yes.
Hi, how are you today?
I'm okay. Been better.
Okay, so. Okay, good morning, Miss Hudson. How are you?
I'm okay.
Can you please verify your date of birth for me?
April 11, 2001.
All right, and can you tell me what you're here for today?
So ever since I hurt my leg, I just had surgery and I've been laying in bed a lot. I just feel my leg aches so bad at night. I just feel like I can't get comfortable.
Okay, and that is an ankle surgery, correct?
Yes.
Okay. And do you remember what the surgery was for? I see here in your chart that you did have ankle surgery. This was recently?
Yes, they did a ligament repair for my left ankle.
I'm sorry that you had to go through that.
Yeah, it was rough.
So tell me a little bit about like your daily routine, like when you wake up in the morning to when you go to bed.
The most I really get up is just to like get to the bathroom and stuff, but I've been laying in bed a lot lately.
So you would say you only get up when having to go to the bathroom?
Yes.
And then otherwise you have your feet propped up or they're laying down?
I have this leg propped up like pillows.
Alright, so here it says that you listed that your symptoms were aching, throbbing, symptoms worsening at night, you're uncomfortable a lot, you have sleep disruption, and then the only relief is when you are actually walking. Is that correct?
When I'm up, yes.
Okay. But I assume it's very painful to walk because of your surgery. Alright. And so the current medications I have you on are naproxen, aspirin, and oxycodone, and I would assume the aspirin is to prevent blood clots since you're not mobile, okay? And is there anything else that you're taking that I need to be aware of?
No.
And then when did this start? Like right after surgery? Did it take a couple of days to come on?
It was like the third day after surgery. I'd say I noticed it the worst. It's just gotten worse at night while I'm trying to sleep.
Okay, and can you describe what that pain feels like?
It just feels like a throbbing, like my leg. I feel like it's like tingling and just throbbing, and it's just really uncomfortable.
And is there anything that you've tried to help relieve the pain?
My mom got me a weighted blanket, but it hasn't done much for me.
That is really good. I wish that would help, but maybe there's some other things that we can do. As of right now, what would you rate your pain on a scale of 1 to 10?
7.
Okay. And then at night, would you say it's a 7 or would you say it increases?
It gets worse.
So about a 10?
Yeah. Sometimes it's really bad.
Alright. And of course, I do have to ask this question. Are you feeling safe at home? Do you have any worrisome? Oh, safe at home. That's good. Glad you're keeping her safe.
Of course.
So everything as far as your blood pressure, temperature, all looks great. So what I'm gonna do is I'm gonna do a little assessment on your other leg, make sure we can knock out anything else that it could possibly be, and then we'll go from there.
Okay.
First off, let me get some hand sanitizer. Alright. always gotta make sure these hands are clean. Don't know how many patients I touch a day. Get some yourself. Alrighty, so what I'm gonna first do is I'm gonna take this little handy dandy thing and tap your leg a couple times. Okay, are you ready? Okay, well that doesn't seem to be an issue. The bones seem to be intact. Let's see your range of motion. Everything looks good from that perspective. Can I have you like do some leg raises a little bit? Pain with any of those movements? Everything feels fine?
Yeah.
Okay. Let me go ahead and get your, check your heart. Sounds good to me. Alright, so now that we've got that taken care of, let's discuss your treatment plan. The things that I was checking for were like bruising, any type of like blood clots. I was checking for like sprains and strains, maybe limited range of motion. However, I didn't find any of that, so that makes me believe that it could be restless leg syndrome. Have you ever heard of that? Are you familiar with that? What is that? So restless leg syndrome is a sensory motor disorder usually characterized by the irresistible need to move your leg. That's like typically the main symptom. However, you're presenting a little bit differently. However, you do meet the other characteristics such as like the restlessness, trouble sleeping at night, pain getting worse at night, and you do say that you have relief when walking. So I do feel confident in this diagnosis. With that being said, there's a couple different things that we can try. I typically do not like to try the medication route, especially since your post-op have a lot of medications already in your system. Melatonin, that is something that we like to try. It could be a 5 milligram tablet. It's not going to do a whole lot of harm with your other medications, shouldn't have any interactions. However, if you start feeling any type of different ways and you feel like it's not helping, then you can just discontinue that. Also, I would recommend some lifestyle changes. You mentioned that you do drink a lot of coffee, correct? Yes. So how many cups a day would you say?
At least 2.
Okay, so let's try to limit the coffee intake because I know
it's gonna be hard.
I know. Considering I drink like 8 cups a day, you'd think I have the same thing, but I don't. Luckily. So, however, let's try to eliminate. Let's start off with 1. Okay. I feel like that's reasonable, correct?
Yeah.
You're probably a college student, right?
Yes.
What's your major?
Psychology.
Oh, I was bio and science. Anyways, so how do you feel about moving around more?
I can try to like get up, and just the crutches right now are pain, but I can try to get up more.
So would it be reasonable to say let's get up every hour and maybe walk at least 50 steps? Is that reasonable? I know 50 steps may sound like a lot, but if 50 steps are getting easier, increase it. If it's getting harder, decrease it. Okay? I just want you to have some type of movement every hour to make sure you're getting that blood flow to your legs, and you need to tire yourself out a little bit. So currently in your treatment plan, what I have here is we're going to limit your caffeine intake to 1 cup a day. We're going to start moving at once every hour, at least 50 steps, and then we can adjust based on your pain level. And then you can try the melatonin. I don't know how comfortable you feel with that. And then let's follow up in just 2 weeks. Good for you? And do you have any questions about anything? Anything that I should be knowing about? Do you have any concerns with the surgery? Like, is everything going well?
Everything's going well with my surgery. I'm doing well.
That's good.
Yeah.
Alright, so I shall see you back here in 2 weeks. If anything happens, if there's something I should know about, please give my office a call immediately. We can get you in earlier if something happens. But let's just try 2 weeks, and if there's no changes, then we can further evaluate. Thank you. Thank you. Good morning, Miss Hudson.
Hi, how are you?
Good. So it's been about 2 weeks since our last visit. Can you tell me how everything's been going with the changes that we made?
I've noticed a little bit of change. It's a little bit more tolerable throughout the day. I don't feel as bad, but nights are still hard for me.
Okay, and I know last time we discussed that you had a pain of 7 at the time and 10 at night. Is that any worse, any better?
It's a little bit better. I wouldn't say a 10 at night. It's getting a little bit better, but it's just still, I just feel like I can't get comfortable.
Okay, so it's still, not what we want, obviously. How about the caffeine intake?
I've cut back to 1 cup a day.
Do you think that had any changes or?
It probably helped a little bit. I think between like that and getting up more throughout the day.
Yes, so were you able to do 50 steps? Did you have to increase or decrease any?
It just depended on the day. I was able to do at least 50 steps.
Okay, awesome. I'm glad to hear that. So, I do think it's great that we've had some improvement in pain. However, you're still not sleeping the best. You're still reporting some symptoms. So I did say that we could reevaluate your treatment plan. So my recommendations are, these are little circulation. Since you're not moving around, they're basically helping pump the blood for you since you're not doing it by movement. So basically, I can show you how we can use these. Mom, I'm sure you'll probably be the one doing this, so you're just gonna undo this right here.
Okay.
Have to lift up her foot, and then we're just going to do this right here, and then you just press this button.
Perfect.
And it turns on, and what it's gonna do is it's gonna act like kind of like a blood pressure cuff. It's gonna squeeze, inflate, make sure to move those muscles around. She can use this however often you'd like. This is just going to help the blood flow, and it should help decrease the pain. I can even give you 2 if you would like to use it on the other leg too. That would really help your pain a lot. I know we discussed the melatonin. I'm going to go ahead and take this off. Probably not best for you right now.
I can just take that from you now if you want to.
Oh, yes, that would be perfect. If you have any questions about how to use it, just call my office. So with the melatonin, did you use any of that or?
Yeah, I got was it the 5 milligrams?
Yeah. Okay, and you were taking that before bed, correct? And did that help any or?
I would say it helped a little bit when you falling asleep. I would wake up in the middle of the night.
Great. So let's go ahead and try the leg cuffs and see what that does. You said you're still using your weighted blanket, correct? Okay. And I think I'm gonna go ahead and recommend some physical therapy.
Okay.
Just because you have your foot surgery, they could probably do a little bit. They can help you with both, honestly.
So work on both at the same time.
Yes, especially since you have that leg hurt, you don't want to have both of them in pain. I know that could be miserable. So I'm gonna recommend physical therapy. I would say 1 to 2 times a week. Would that work with your schedule? And do you have any preferences on physical therapy offices or?
Not really. I don't know.
No, just
closest.
And do you guys have any questions, concerns?
Would this be like with her whole life? This like syndrome, or I mean, I imagine physical therapy will help a lot, so hopefully that will.
It should not continue her whole life. Most of the time, this is an acute syndrome, meaning it lasts less than a year. There's been very few cases that have lasted longer than that. So hopefully, with this physical therapist, everything should be fine. And I'm assuming that your other leg is like bothering you a lot too, and that could be causing some more symptoms in that leg. So this time I'm gonna follow up in a week because I think I'm confident enough with the physical therapy with the leg compressions that you should be feeling much better. However, if there's any problems, if you're not feeling any relief with the physical therapy, if there's something worsens, just please let me know and we'll reevaluate again. Okay, great.
Yeah.
All right. Thank you guys.
Thank you.
Thank you.
Alrighty, great job. That was fun. Thanks for doing that. Right, so the group that offered to go next is our autism spectrum disorder group. So that's Jasmine, Allie, Charleston, and Madison R. So y'all can share screen, do whatever you need to do, and I will start pinning you.
Alrighty, I'll go ahead and start sharing my screen.
Go for it. Yeah, I'm just really slow with pinning for some reason. I don't know why.
Alrighty, can you see it? I just want to make sure. Alrighty. Let me go ahead and do that. Oh gosh, sorry, the present button is over here. Okay, we're good. All right, so yeah, we have autism spectrum disorder, and we all kind of chose a slide to do. So I'll go ahead and let whoever did theory go first.
Okay, so for theory, autism spectrum disorder, can you hear me? Okay, I just wanted to make sure. Autism spectrum disorder is characterized by problems in social interactions, problems in verbal and nonverbal communication, and repetitive behaviors. Atypical responses to sensory experiences may be present as well. So research shows that autism is a brain dysfunction characterized by abnormalities in brain structure and neurotransmitters. And recent research focuses on brain networks and the lack of connectivity between brain regions. And some research says that genetic factors are also said to play a role. And then on the next slide, we should have a video.
Yep.
Meet your next pillow.
This isn't the video.
Why do we make our pillow in the shape of a cube? I'll tell you. The problem with pillows is that you're trying to fit a round.
Beginning about 15 years ago, there's one property of human intelligence that scientists got very interested in, and it's called having a theory of mind. And the best way to describe it is to describe a classic experiment with human children. So imagine you're sitting around and you're telling stories with your younger sister. And you tell them a story, say, well, here's Sally. And Sally has a bowl that she really likes, and she's going to put it in the basket, which is right there in front of her. And she hides the ball in the basket. And
We lost the sound, so who's ever sharing the video
takes the ball out of the basket and puts it in a box, a green box that she's got next to her. Now Sally comes back into the room and she wants to play with the ball. And supposing you ask your sister, where is Sally going to look for the ball? If your sister is 3 years old, she'll say, in the box, because she knows that's where the ball is. And a 3-year-old has knowledge, of course, but can't imagine that other people have knowledge that's different from her own. So if she knows the ball's in the box, everybody knows the ball's in the box. And that's because a 3-year-old doesn't do what scientists call attributing mental states to other people. She doesn't think that other people have thoughts, desires, beliefs, knowledge. So she answers the question incorrectly. As children get older, it happens pretty quickly, 4, 5 or so. They go through the same test and you ask them the same question and they begin to say, well, Sally's going to look for the ball in the basket because that's where she thinks it is. And a 5 or 6-year-old will say she'll look for the ball in the basket because she thinks incorrectly that the ball is still in the basket. But I know it's been moved into the box. So by 6, children have the ability to attribute mental states to others. They have what we call a theory of mind. And we call it a theory because there's nothing about the other person that shows that they're thinking. Thoughts are hidden. We don't see them. The only way we can imagine that thoughts are there and that they cause behavior is if we have a theory about the way the world works. People have thoughts, and the thoughts cause them what to do. And of course, humans are, theory of mind just pervades all of our life. We're forever making a distinction between what people do and what they think we do. I mean, think about your relationships with other people. Yeah, she was nice to me yesterday, but does she really like me? Or, I think that he doesn't know that you really do like him. These things can get incredibly baroque, where you're attributing theory of mind back and forth to three other people. And it's what we do in plays, it's what we do in our daily life all the time. But it's not something we're born with. You've got to learn it.
Oh, no. There we go. Sorry. I pressed the wrong thing. All right. Next is going to be symptoms.
And so for the symptoms, the article that I found broke it down and I really liked it. So that's what I'm going to go over. And it broke it down into different like deficits. And so the first one is deficits in social emotional reciprocity. So abnormal social approach and failure of normal back and forth communication. Deficits in nonverbal communication behaviors. So abnormalities in eye contact and body language. Deficits in developing, maintaining, and understanding relationships. So difficulties adjusting behavior to suit social context, difficulties in play or making friends. And then on the next slide, it broke it down into restrictive, repetitive patterns of behavior, interest, or activities. So repetitive motor movements, use of objects or speech, so lining up objects or toys, insistence on sameness and flexible adherence, so extreme distress at small changes and difficulties with transitions, and highly restricted, fixated interests that are abnormal in focus, so strong attachment with unusual objects.
And then I had assessment, and that's just to put it kind of blatantly. Assessment is just where like a psychologist, sorry, or a professional goes and tries to assess a child to see if they might be at risk for having autism spectrum disorder, or if they do already have it. So it can be detected in children, sometimes as young as 18 months. However, by the age of 2, a diagnosis by a professional will be more reliable. Usually, that's when the official diagnosis comes through. And then when diagnosing a child with autism spectrum disorder, a professional will look for like the early signs of the disorder, such as like avoiding eye contact, such as Ali had mentioned, having little interest in other children or their caretakers. So like if they're at preschool, they're just not wanting to do anything with anybody. Getting upset by extremely like minor things. It might be minor to us, but it's not to them. And then having a limited display of language. So when monitoring a child for autism spectrum disorder, by looking for like the typical developmental milestones as they grow, that can be a really strong indicator in an early diagnosis. And having an early diagnosis in this case is going to be very important, because the sooner the child gets help, the better their quality of life is going to be. So like typical developmental milestones is like rolling over at a certain age, starting to like use their hands, shape recognition, stuff like that. So the American Academy of Pediatrics actually recommends that parents take their child to get developmental and behavioral screenings at the ages of 9, 18, and 30 months. And then all children should be screened specifically for ASD, well, autism spectrum disorder, at 18 and 24 months. And this is going to be especially important if another family member, such as a sister, brother, mother, so on and so forth, was diagnosed with ASD. This can help them, especially in helping them cope with their disorder and trying to figure out a way to still sorry, I completely just lost my train of thought. Trying to basically just give them the best quality of life possible, so this way they can still take advantage of their childhood. Next is treatments.
For treatments, I found a bunch of different types of treatments, but there are 4 that I want to touch on. So the first one is applied behavioral analysis, and that is, it applies our understanding of how behavior works to real situations. The goal is to increase behaviors that are helpful and decrease behaviors that are harmful or affect learning. And they mainly use positive reinforcement to help this. Next, you have the early start Denver model. Floor time and occupational therapy was another one that I wanted to highlight. In occupational therapy, it helps people work on cognitive, physical, social, and motor skills. The goal is to improve everyday skills, which allow people to become more independent and participate in a wide range of activities. Then you have the pivotal response treatment. And another one that I highlighted was the relationship development intervention. This is a family-based behavioral treatment which addresses core symptoms of autism. It focuses on building social and emotional skills. Parents are trained as the primary therapist in most RDI programs. RDI helps people with autism form personal relationships by strengthening the building blocks of social connections. This includes the ability to form emotional bonds and share experiences with others. Also, other treatments are speech therapy. Teach it's like a brand of therapy that they have. I think I need to highlight this one as well. Yes. Teach is an autism program. It is clinical training and research program based in the University of North Carolina, Chapel Hill. It is developed by Dr. Eric in the 1960s. It was established as a statewide program in 1972. The model for the program around the world, the program in 1972 has become a model for other programs around the world. Teach uses a method called structured teaching. This is based on unique learning skills of people with ASD, including strengthening visual information processing, difficulties with social and communication, attention, and effective function. And then you have verbal therapy. Can you click to the next slide? And then the other treatments are medications used to treat a variety of other medical conditions like epilepsy, gastrointestinal problems, feeding, sleep disorders, attention deficit hyperactivity disorder, anxiety, depression, and obsessive compulsive disorder.
So the quality of life issues, the first thing we talk about is a possible delay in vocabulary development, which leads to inabilities in efficient communication. So when you already have a delay in vocabulary, we're talking about like early on, you see this delay when you compare them to, one might say, like the normal time period for being able to say complete sentences and being able to, piece together definitions that go effectively with, what you're saying, understanding words and what they mean and placing them in proper order. When you have children with ASD that have a little delay in the vocabulary development, it's kind of harder for them to express themselves as they grow up. So you have situations where a child may feel sick and not know how to effectively express it. A child may feel uncomfortable in certain situations, but don't know the proper words to piece together in order to let their parents or guardians or even a teacher know. Deficiencies in motor skills can lead to an inactive lifestyle, which tends to result in obesity. So if you have a child that's, like I said, deficiencies in motor skills, so having the inability to, let's say, run straight or things like that, just due to the fact that there are, like, your brain is involved, so there are certain portions that are supposed to be connected, and when you have I don't want to say loose strings, but you know what I'm saying? You have the certain portions that are not correctly intact, which we see a lot of with children with ASD. Their motor skills are affected and kind of leads them to not being able to interact with other youth as much as possible, even as they transition to adult years, which tends to lead to a lot of obesity because of the inactive lifestyle, unless there's a situation where there's somebody that's actively working with them to help, kind of divert them from that. Abnormal electrical activity in the brain leads to possible seizures. 1 in 4 children with autism experience seizures in early childhood. So, that kind of does explain itself, the abnormal electrical activity in the brain. So most children with ASD have this. And sadly, when the seizures, their body will seize up. They can lead to like a lot of vomiting, and it interrupts their quality of life, especially when it comes to education. So if a child is always at risk of having a seizure throughout their school day, or even as they transition to adulthood. So let's say they have a situation where it's constant seizures. It can interrupt their abilities to acquire jobs or keep certain positions. Many children with ASD have unbalanced senses, unbalanced senses, such as a greater sensitivity to noise. Sorry, the chat came up and it blocked the last word off. So I'll give you a personal example. A young man I know from CBA, Chesapeake Bay Academy, is very sensitive when it comes to loud noises. So every time there is a fire alarm, they have to give him or a fire. You know, the routine when they're, you know, this is just a practice. They have to give him specific headphones to ensure that he does not overreact. And then if you're not in a controlled environment like that, let's say you're at walking by a construction site or anything like that, a person with ASD that has a greater sensitivity to noise could immediately physically shut down due to the loud activity going on. And that can really disrupt every portion of their life, because unless you're in a controlled environment, you can't really stop whether or not, there's going to be loud noises or things like that. So there's a lot of factors that come into play when you talk about their quality of life.
These are just some of like the references that we had used. I actually had forgotten to put the website that I used, but I'll add that after the presentation. So this is like to click if you guys have any questions, you just want to kind of learn some more about autism spectrum disorder, stuff like that. And that's pretty much it.
All right, great job, y'all.
Thank you.
All right, so the next group we have is our necrophilia group. So I'm going to go through and remove these pins, and then I'll pin the next group.
Hi, that's us. I'm trying to share the screen.
Yeah, let me know if you have any problems.
All right, you should be seeing that. Are you seeing that? Okay, good. All right, so we're going to be talking about necrophilia, which is the sexual intercourse with or sexual attraction towards corpses. And necrophilic desire can be any kind of desire that implies the eroticization of a corpse, of a dead body. So different theories explain it from different perspectives. We're going to be discussing psychodynamic perspectives and cognitive behavioral perspectives. So there's different themes that appear in psychodynamic theory, and they're not mutually exclusive, but there's a few. They talk about unconscious suppressed hostility towards the parents, the parental figures, and sadistic impulses to explore the mother's body. In that same vein, they talk about when there's bizarre mutilations present in some kind of sexual homicide that involves necrophilia. They say there's a wish to re-enter and to explore the interior of the mother's body. They do say that there might be a genetic factor or some kind of brain malformation or abnormality. And they talk about the need to overcome the primal scene trauma. The primal scene for psychodynamic theorists is the actual or imagined observation of parental intercourse by a young child. And the child basically misinterprets the sex act as the father attacking the mother, which obviously causes great anxiety. And to them, this would cause an unconscious foundation for necrophilic behavior in adult life. They also say that for people who engage in necrophilic behavior, that person is a safe partner who will never reject or ridicule them, because they do see a lot of fear of rejection in people who engage in this kind of behavior. They say that at first, these people are afraid of the dead. I'm sorry, my dog's snoring next to me, so that's what it is. I'm so sorry. So they're afraid of the dead person, but then that fear becomes love through the mechanism of reaction formation, where an unacceptable emotion is replaced by its opposite. The fear is basically unacceptable because it's the only thing that's preventing them from having this kind of relationship in a way. Cognitive behavioral perspectives, theorists, have done different studies. And they looked at necrophilic behavior in cases of sexual homicide, and some have found as little as 0.3% of necrophilia in sexual homicides, and others have found that 7.9% of people who engage in sexual homicide also engage in necrophilia. And Rosman and Resnick did the largest study to date in 1989, so that was a while ago. They took 115 participants from different case studies, case reports from all over the world. It was an international study. And they found that 17% had psychosis, 56% had a personality disorder, and 64% had a history of sadistic behaviors. So that's much higher than the regular population. So that's an indication that there's high comorbidity and that there's a lot of other mental health issues going on in people who also engage in this paraphilia. They found that only 15% of participants report conscious attraction to human remains. So that indicates really little insight of these clients, and 68% had a fear of rejection and ridicule as the most common motivation. So that's something we found in common between cognitive behavioral and psychodynamic perspectives. The way a cognitive behavioral therapist would assess necrophilia would be to, first of all, identify the problem. As usual, they would do an interview with the client, a file review. They would speak with people close to your client, but indications of necrophilia will usually come from police reports because clients are usually reluctant to disclose deviant sexual fantasies or behaviors. So if these people have been caught doing this kind of thing and they've been reported, that's how a therapist will usually find out. They want to evaluate the presence of other paraphilias. The multiphasic sex inventory is good for doing that, and also of other mental health issues. And they're not encouraged to use confrontational approaches because they've been found to evoke resistance and reduce change. And open-ended questions are preferred because that way the patient can elaborate. They should also perform risk assessment interviews. The second step is to hypothesize the mechanisms. So mechanisms are basically what maintains the problematic behavior going on. And three kinds of mechanisms have been proposed. First of all, sexual arousal. They are aroused by this kind of thought and behavior. Second is sexual sadism, so the power to humiliate and degrade the victim. And the way a therapist would find about the sexual sadism in a client would be to ask about their pornography use and their sexual encounters to see if there's any violent themes that keep coming up. And the third mechanism is intimacy aversion. So that fear of rejection, we were talking about fear of ridicule from a partner, and that is usually found in clients who have insecure attachment patterns. So they have a lot of difficulty engaging in meaningful relationships with other live partners and people. And the third steps would be to identify the precipitants of the behavior. So that would be basically the triggers. So what caused this behavior to actually start? And using the cognitive perspective, they found that usually what happens is that there's a traumatic experience and the person has to make sense of that traumatic experience. Why did this happen to me? And that's how abnormal patterns of thought develop around that trauma, and that creates this this way of thinking, and as a consequence, a way of behaving. That's it for me.
All right, so some of the historical and cultural practices and theories that we found were Egyptians would leave dead women for at least 3 to 4 days before giving them to the embalmer, just to discourage against any form of intercourse with a corpse. Sailors were also accused of necrophilia when returning bodies home for a proper funeral. This was because of the long voyage that they had, the loneliness that was brought on by these trips, and the fact that there was no supervision. Areas in East Africa believed that the ghost of a virgin was bad or dangerous, so someone, even a stranger, would have intercourse with a corpse to pacify it. And in 1865, Kraft Etting described a disorder that consisted of sexual behaviors with human remains, and the motivations were sexual preference and psychosis. So some of the causes are intense fear of interacting with living partners and fear of rejection because a corpse cannot reject, disagree, or manipulate. And then also the enjoyment of being in control, which is brought on by poor or low self-esteem. So there are no specific assessments or interviews or questionnaires, but some of the characteristics would consist of male, being single. They usually worked as a gravedigger, hospital porters, and even embalmers. And sex of a corpse parallels sexual orientation of a necrophile. Also, for psychopathology, it consists of the history of sadistic behavior or acts, psychosis, personality disorders, and an unusual belief system.
Okay, so for the types of necrophilia, there were a few different types. We have them all listed here. These are all they're all very specific, but they're all like kind of based the same in just the types of how they are. I'm not going to go through and read each one, but I will go to treatment. The treatment was talked about a little bit earlier. There aren't many treatments due to the low percentage of people who are necrophiliacs. There's also the cognitive behavioral treatment, and there's also medications you can take to lower your sex drive. The quality of life issues, we took it as the legal aspects, and the country as a whole doesn't handle that. That's done state by state. And for a few examples, in Florida, it's a second-degree felony. In Arizona, it's a class 4 felony. In Hawaii, it's just a misdemeanor, which I know that sounds crazy. And then in Alaska, it's a class A misdemeanor. And then these are references that we used.
Alrighty, thanks, y'all. I think you're the first group in all the years I've taught this to actually do this disorder. So very cool. Thanks for doing something a little different. And I appreciate it. Alrighty, so our last group to go will be our sleepwalking group. So Sydney, Sasha, Jenna, and Anya. I'm going to go through and start pinning y'all, and I'm going to mute myself so I don't forget to do it later.
I was muted. I'm sorry. Okay, so let me go back. So we're doing sleepwalking. I wanted to start off with the history of sleepwalking, and the scientific term for sleepwalking is somnambulism. In the past, there has been some talks about people walking in their sleep, and it goes back all the way to 300 AD. Something interesting was in the medieval times, sleepwalking was actually thought of to be tied to religion and to the devil. And so they think that the devil takes over the person's body, makes them do things in their sleep. And in the 19th century, in the Western part, a lot of people thought it was supernatural. Those people had like supernatural powers, or they were possessed by some type of demon. But it wasn't until later in the 19th century that it was actually fully investigated and diagnosed as sleepwalking, and that was by Ludwig von Reichbach, which we'll get to later. So something about sleepwalking is, we have come a long way with the research, and the EEG has really helped with that, learning more about it. The EEG is basically just electromagnetic waves that kind of track your sleep, your brain activity, and this has led to further research about it. In the DSM-5, some of the criteria that people, for them to be diagnosed, they have to have reoccurring episodes of waking up in their sleep cycle, episodes of getting up while sleeping, and this causes disturbances and distress in their daily life, and we'll get more into depth about that. Something that I found really interesting with the modern view of sleepwalking is with media becoming something that's evolving. I found that TikTok has actually made videos that kind of puts like an entertainment and comedic view on this disorder. It was actually called Sleepwalking Challenge, and I actually have a video on it, and I will show you.
My boyfriend's been sleepwalking, and I put a night vision camera in our living room last night, and this is what I found. I'm scared. Where's the pepperoni? Hot dog. Hot dog, hot dog, hot dog, hot dog. Shh, hot dog, hot dog, hot dog. I'm joking. I don't actually eat meat. It's fine. I don't eat meat. Oh, what? 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 Birdie, birdie. Hey, birdie, 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 birdie. Birdie. Oh, I ate a fart. But now what?
So this person does not actually have this disorder. This couple actually has a pretty big following on TikTok, and it was just made for entertainment. And so I thought it was really interesting how something like it is an actual disorder, people actually do go through it, and it does disturb their daily life, and just the role of media on mental health, it can kind of make fun of it. And so today, I don't know if I think media can be a good thing, like getting the word out about it, but it also can turn it into a comedic thing. So now we're going to move on to theories with Jenna.
Okay, so yeah, okay, sorry. So there are many theories about the causes of sleepwalking. And one of the first theories is from German philosopher and scientist Dr. Reichenbach, and it's called Odic force. And this is named after the Norse god Odin from Norse mythology. And this was the belief that sleepwalking is based on energy like magnetism. And so because of this, the phases of the moon were believed to be influential on sleepwalking, and the full moon was the most influential phase. And another theory was from Freud, because he has a theory about everything. He believed that sleepwalkers were trying to go back to the place that they slept when they were children. And more modern theories include things like genetics, and this is backed by research that states that 61% of children sleepwalk if both of their parents do, while only 22% sleepwalk if neither parent does. Medication can also be a factor. It can sedate people, which leads to deeper sleep, which increases the chances of sleepwalking. Alcohol can alter the sleep stages, which could also lead to sleepwalking. Sleep interruptions like sleep apnea or restless leg syndrome can lead to sleeping extremely lightly, or even not being able to sleep, or not being asleep, but not realizing you're awake. And the pictures here are from the data my watch collects while I'm sleeping. In the orange, everywhere you see orange is where I apparently woke up, but in all of those cases, I didn't realize I was asleep. I just thought I slept straight through. I mean, awake. So I thought I just slept straight through. So I thought that was interesting. And another theory is sleep deprivation, which is just that not getting enough sleep one day increases your chances of deep sleep the next day, which increases the likelihood of sleepwalking. So in this first picture, I got about 6 hours of sleep, which isn't that bad, but coupled with the fact that I didn't go to sleep until almost 7 a.m. the next morning could be considered slight sleep deprivation. And so I went to sleep into deep sleep a lot more on the second day than the first day. And you can see that in the pictures, the very bottom, it says deep. I'm not sure if you can see it, but you can see it goes down to the deep level more often, and that increased my likelihood of sleepwalking.
Symptoms.
Okay, so moving into symptoms, sleepwalking is characterized by the abrupt onset during stage 4 of non-REM or rapid eye movement sleep. This is generally occurring without any effective distress, and sleepwalking episodes may generally last a few minutes. There's also noticeable dysfunction between cortical and subcortical brain areas. So by that, I mean that there are certain parts of the brain that are awake and functioning, and others that may be more sedated or not functioning as well. There's also involuntary ambulation or sleepwalking while an individual is being aroused from a deep sleep. There can also be a verbal element characterized by screaming, mumbling, or swearing, and that's dependent on the individual. There's a lack of awareness or consciousness, and also inappropriate or dangerous behaviors to self or others. So to self, there's a huge risk for injury, and that also applies to others. I found in research that there was an example of having superhuman force, so that could be a potential threat to other individuals. And there's also subsequent amnesia, which is a poor recollection of events. And then moving on to the next slide. So going into assessments, these may be carried out in sleep clinics. It's generally characterized by an interview or a consultation with the patient, a significant other, family, or other witnesses. There's also video sleep monitoring, which is helping to document any actions or behaviors that might otherwise go unnoticed. And then there can be the use of psychological exams just to determine any like characteristics or behaviors that could be problematic or a risk factor for sleepwalking. And so on the next slide, I have an example of a personality questionnaire. So this is one that can be used to kind of assess any behavior characteristics. So it's a series of yes/no questions to determine your level of neuroticism, among other factors. And so based on the quantity of yes or no responses, that determines the strength of certain behavior qualities.
So there's no standardized treatment for sleepwalking because there's differences in each person, like how often they sleepwalk, how dangerous sleepwalking is for them, how old they are, and other things like that. But the first step in all treatments is to make sure that they can't hurt themselves or other people. And this includes things like locking up sharp objects, locking doors and windows, and maybe even putting nightlights in the hallway. The next step is to eliminate the possible causes of sleepwalking. So if it's caused by something like sleep apnea or restless leg syndrome, treating those conditions can reduce the risk of sleepwalking. Cognitive behavioral therapy can be helpful for people whose sleepwalking is caused by negative things. For example, if their sleepwalking occurs because of extreme stress, which could be a sleep disruption, then working through the stress can reduce the chances of sleepwalking. Adjusting the medication that somebody takes can also be helpful if the medication is part of the cause. And medications that can be a factor in the causes of sleepwalking are benzodiazepines, antidepressants, and melatonin. And one thing that some people try is anticipatory awakening. And this is most effective in children that sleepwalk, but basically someone wakes the person up before they get to the sleep stage that people sleepwalk in. And this keeps the person from sleepwalking because you're waking them up. But this isn't as effective in adults because children seem to be able to go back to sleep easier. And adults may end up being sleep deprived, which is, of course, another possible cause of sleepwalking.
So I'll be discussing the quality of life of sleepwalking. So starting off with daytime sleepiness, which is basically the inability to maintain wakefulness during waking hours. So if you're having trouble staying up in class or staying up on your job, or you find yourself just like taking naps throughout the day and you normally wouldn't, that's a way to that's a way to also enhance your sleepwalking at night when you're taking certain unplanned points of rest throughout your day that you may not normally take. Also fatigue, which includes headaches, dizziness, sore or aching muscles, which I think a lot of people sometimes forget about when it comes to sleepwalking, that when you're up all night doing this, you can suffer from really bad headaches the following day. Also insomnia, which is of course a sleep disorder in which you have trouble falling and or staying asleep. And insomnia plays a huge factor into sleepwalking. For those people that stay up long nights, again, the next day, it can result in you having an episode of sleepwalking, or again, the next day, going back to the point before that, being fatigued and having a headache. Also, depressive and anxiety symptoms are a result of sleepwalking. Me personally, I am a sleepwalker. I'm not as bad as I used to be, but I would definitely say that anxiety plays a huge part in being a sleepwalker because you have to think about nights when you're going to stay out with a friend or you're staying with other people. You're constantly worried that you may have a sleepwalking episode in front of your friends or your family or someone you never met. And a lot of people, they're unaware of how to approach someone who is currently sleepwalking. So in the next slide, I talk a little bit about how my parents were able to help me to cope with my sleepwalking. When I was younger, I was a very, very bad sleepwalker. My mom wouldn't, so not only does it affect your personal quality of life, but it affects the quality of life of the people around you, like your peers, your siblings, and your parents. And so my parents had trouble allowing me to stay out with different friends and stuff because they were fearful that I would, sleepwalk. One particular time that both of my parents often remind me of is the time that I got up and walked out of my bed to the front door of our house. I had stepped onto our porch. And at the time, we were living in Washington, D.C., and there were a lot of steps to go down. And I didn't fall down those steps, but I almost fell down our porch steps. And both of my parents heard me. And so what happened was my mom had to start placing buckets of water on the outside of my bed so I could step in it and wake up. And that definitely had an effect on me when I first got into sleepwalking because it kept me up the next day at school. I was super tired all day because I've been up all night stepping in different buckets of water all throughout the night. So that's why I would say it's very important when you're thinking of stuff like sleepwalking to think of the personal, strain that it has on someone who does have this disorder. I don't sleepwalk anymore, but I do talk in my sleep quite a lot.
And these are our references.
Great job. I'm super impressed because you came in like right at time. So good for y'all, especially since I was not good because I was so wrapped up in your presentation about telling you the times. So great job. Okay.
Great job, y'all.
Yeah. So a couple more things here. First one, big one. I'm going to throw this in the chat. It's also on Blackboard. So this is a form that you're going to fill out to rate your group members. Do it now. Just get it over done with. And so you should do one for every member of your group, including yourself. So if there were 4 members of your group, you do 4 of them. And you fill it out for yourself. So, be honest about how good or bad you were. This is just, I do this for when I do group projects because it's my proxy for, I can't be in the room with y'all when you're working outside the classroom, right? So this is the only way I know if everyone was rock stars or if, someone didn't pull their weight. I can find out either way. So typically people really supported each other, but we don't always see that. I want to personally apologize because I totally butchered Anaya's name. I wrote her a little note in the chat that, you know, I shouldn't talk and click at the same time. So I want to apologize because names are important. Any questions about anything? My hope is to finish grading the presentations this afternoon and get your grades posted. So you should hopefully know either today or tomorrow how you did in this class. Thank you for being understanding. I'm somebody who my name was butchered for years. I was called Taran instead of Taryn. So
Is it completely too late to turn the if you already took off 4 exams and wanted to drop the lows?
So if you want to turn in the media paper, I would say turn it in by like 1 today, because that's about when I'll finish with my psych and the law presentations, and I'm just going to start grading. So if I don't have it by then, I'm going to assume you're not doing it.
Yes, ma'am. Got
Any other questions? Well, I have just really enjoyed you all this semester. You have asked such great questions. I feel like you supported me when I was going through some rough times, so I appreciate that. And congratulations to those of you who are graduating. I will be at the social science and the natural science ceremonies helping out. So if you're there, make sure you say hi. And then for those of you who are continuing on, I look forward to having you. I think I have some of you this summer in classes and some of you in fall. So I'm excited to see you again. If you end up having any questions about anything, just email me. Your grade will be obvious where that came from. I literally just use the grades on Blackboard. And usually if you're within a point of the next grade up, I round up. Otherwise, you know, what you see on Blackboard is the grade you get after I put everything in. So if you have questions as to why your grade is what it is, go to Blackboard first. And then if you don't understand, shoot me an email. But I think there's often like a knee jerk, like, oh my God, how did I get this? And like, if you go to Blackboard, you'll see, right? So definitely make sure you do that. I'm also gonna go through and put in zeros for missed assignments on Launchpad this afternoon as well. So your grades might change slightly because of that. But do remember you had like, I think 3 freebies. So if you didn't get to all of them, you should still be okay. And they're only 10 points each out of whatever 800 or 700 points we have for the semester. So, alrighty. Well, take care of yourselves. Have a good summer. You know, wear your masks if you are around people that you don't know their vaccine status. And yeah, I'll be available via email and appointment all summer if you have any questions. And enjoy. And again, for those of you graduating, I will see you on Saturday. Yes, if there's anyone who needs to stick around after class to talk to me, you can feel free to do that. Aw.
Thank you so much. We appreciate it.
Thank you for everything, Dr. Myers. Have a good summer.
Thank you.
Dr. Myers, I had one quick question. So you know how